The following podcast is part of a certified educational activity titled Implementing Immuno-Oncology in Gynecologic Cancer Care for Veterans, Expert Insights on Personalized Treatment. Access the entire activity and complete the post-test at peerview.com/DVK860. Downloadable slides and practice aids are also available.
Hi, everyone, and welcome to Implementing Immuno-Oncology in Gynecologic Cancers for Veterans, Expert Insights on Personalized Treatment. Today's panelists will be myself. My name is Haley Moss. I'm a gynecologic oncologist at Duke University, and I also treat patients at the Durham VA, and my colleague, Angela Alvarez-Secord. If you want to introduce yourself, Dr. Secord.
Sure, I'm happy to. Thank you so much for having me on here, Dr. Moss. It's a pleasure to be here with you today. My name is Angela Alvarez-Secord, and I am a GYN oncologist at Duke, and I'm the Director of Clinical Trials and the Associate Director of Clinical Research.
Okay, so to go through our goals today. So first, augment your knowledge of clinical evidence supporting the integration of immunotherapy platforms for cervical, endometrial, or uterine. You'll hear us use both words sometimes interchangeably, and ovarian cancers. Second, equip you with strategies to construct evidence-based treatment plans with immunotherapy regimens across gynecologic cancers. And third, provide guidance on implementing team-based strategies to mitigate, identify, and manage adverse events related to checkpoint inhibitor regimens in order to improve patient outcomes. So we're going to talk today about gynecologic cancer care, insights for the veteran patient population. Okay, so first, we're just going to start off by briefly reviewing some epidemiology of gynecologic cancers. So there are approximately 13,000 new cases of cervical cancer diagnosed each year, with approximately 4,300 deaths, and the 5-year survival is 68%. Unfortunately, approximately 50% of patients diagnosed with cervical cancer are diagnosed with locally advanced or metastatic disease, and this is the patient population we'll be talking about during our presentation today. As for uterine cancer or endometrial cancer, this is the most common gynecologic malignancy, with 70,000 cases per year and 14,000 deaths. This is one of the few cancers where epidemiologists are seeing an increase in incidence and mortality over time. The median age at diagnosis is 64, but we are seeing the endometrial cancer in younger patients each year, with a 5-year survival of 80%. Approximately 1/3 of patients with uterine cancer are diagnosed with advanced stage disease. Ovarian cancer has the highest mortality rate of the gynecologic malignancies. There are approximately 21,000 cases per year and 12,000 deaths. The majority of patients are diagnosed with advanced stage disease, and the 5-year survival is approximately 50%. I just said in the last 2 decades, we've seen decreased mortality rates for cervical and ovarian cancer, thanks to the HPV vaccine, cervical cancer screening, and new treatment options for patients with advanced stage disease. But unfortunately, we're not seeing this with uterine cancer. So unlike most other cancers, where we're seeing improvements in mortality and incidence, the mortality rate for endometrial cancer is actually increasing, particularly since around 2007. We're going to go through that a little bit more. In this slide, there are 2 graphs. The teal line shows mortality rates for patients with ovarian cancer, and the purple line reflects mortality rates for endometrial cancer. The graph on the left depicts all races, and you see the decreasing mortality for ovarian cancer over the years, and you see increasing mortality for endometrial cancer. The graph on the right highlights the disparities for Black patients. Black women are more likely to die for endometrial cancer compared to white women, and Black patients have an 80% higher mortality rate. And this is one of the greatest disparities we see among any solid tumor, not just gynecologic cancers. So now we're just going to switch focuses for a second and just talk about our veterans. So women were first granted the right to serve as regular members of the military following the end of World War II. But at that time, there was a cap of 2% of active duty being women. So only 2% of active duty would be women. And this did not change until 1967. And so this is when we start seeing significantly more women recruited into the military. And then we start seeing more women being cared for at the VA. The number of women active duty and National Guard really skyrocketed in the post 9/11 era. And the combat exclusion ban, meaning those in the military who could actually participate in combat, that ban wasn't ended until 2013. And so now today, approximately 20%, 18 to 20% of the military is women, and that number continues to grow each year. This is a graph looking at the number of women who are VHA, so Veteran Health Administration users, who are women between 2000 and 2023. And you see between 2000 and 23, just like a real significant increase in the number of women we're seeing in this healthcare system. And it's almost doubled in the last decade, which is, really huge. So VA healthcare is a national leader in veteran-centered care. The Department of Veterans Affairs is the largest integrated health system in the United States, providing comprehensive, high-quality care to millions across the country. There are over, I think it's like 1,200, around like 1,200 healthcare facilities across all the states and territories. VA providers are often duly appointed, like myself, with an academic medical center. And most importantly, the VA trains approximately 70% of physicians in the United States. And across the country, a lot of academic medical oncology resident fellowships are, those fellows are providing care within the affiliated VA. So this is a really cool program that the VA started in 2020. It's called VA's National Tele-Oncology Program. And so this was created in 2020, and the NTO, or National Tele-Oncology, provides care to veterans at 122 facilities across the country. This is just so important given that a lot of our veterans, so 42% of our veterans that we care for, are living in really rural areas where access to subspecialized cancer care may require significant travel, particularly for, gynecologic oncology care, which is like, very, very sparse compared to some of the other subspecialty fields within medical oncology. So NTO has subspecialized oncologists in all areas of cancer care, and it has been a privilege of mine to be the gynecologic oncologist on this team caring for veterans. So I'm in North Carolina. I have patients who are getting chemotherapy and immunotherapy and targeted drugs in California, Mississippi, North Dakota, San Juan, Puerto Rico, Kentucky, and it's a real honor to participate in this program. As part of NTO, we created something called BGSOE, which stands for the Breast and Gynecologic Oncology System of Excellence. And my team provides oncologic services to veterans through NTO. And we could also provide e-consults and second opinions for local oncologists. We have a biweekly tumor board that meets to review complicated cases. And I've recruited gynecologic oncologists all over the country to participate, and that occurs every other Wednesday. So veterans with gynecologic cancers exhibit unique demographic characteristics. So despite the rising incidence of these cancers among veterans, we really don't know that much about this patient population. In order for the VA to effectively develop programs and enhance care and understanding of the unique characteristics of veterans with breast and gynecologic cancers, is essential for us to provide the relevant services, and also to answer some, lingering questions about whether or not environmental exposures during deployment leads to more aggressive phenotypes of cancer. So while there's limited research, this next slide shows a graphic of a poster I presented at Avaho a couple years ago. So my team created this study, and we're actually looking to publish it soon. But what we have done here is compare a veteran population with the general population using SEER data. And what we found is that veterans with gynecologic cancer are often younger, and there's a higher representation of Black patients. And these findings just emphasize the importance of a tailored strategy and programs to provide optimal care for veterans. So now turning to just what it's like as an oncologist to treat a veteran population. So we have found that some veterans have declined germline or molecular testing. And, that's obviously very important for our discussion today about which patients might benefit for immunotherapy. But the concern is out of the veterans are concerned that they might lose service-connected disability benefits if they are found to have certain mutations. So the fear is that if their cancer was considered service-connected, meaning through the PACT Act and various legislations, a veteran can claim that their cancer was caused by some deployment or some experience they had while in the military. And so if we find that maybe that person had a baseline predisposition to developing cancer, such as having Lynch syndrome or a BRCA mutation, the fear is that they'll then lose their benefits to the VA. And so it's really important that clinicians reassure their veterans that testing will not affect their benefits at all. I can't stress this enough because this is constantly an issue in our clinics. So now we're going to talk a little bit about, what we're going to be talking about today related to immunotherapy. So many on this call are already probably very familiar with the mechanism of action of checkpoint inhibitors, but I'll briefly review it. So there are checkpoint proteins such as PD-L1, then they exist on the tumor cells, and there's PD-1, which are on the T cells, and they help keep immune responses in check. So the binding of PD-L1 to PD-1 keeps T cells from killing tumor cells in the body, and that's what you see on this left panel. If you block the binding of PD-L1 to PD-1, either using an anti-PD-L1 or an anti-PD-1, this allows the T cell to kill the tumor cells. So I often describe it to my patients as like cancer cells can sometimes hide from the immune system by using a cloak or a shield, and immunotherapy is like immune checkpoint inhibitors help remove these disguises, allowing the immune system to recognize and attack the cancer. And trial after trial, which we'll discuss, have shown that checkpoint inhibitors greatly improve outcomes, particularly for MMR deficient or MSI tumors, compared to our traditional cytotoxic agents. In general, both MMR, immunohistochemistry, or microsatellite instability testing are used to assess mismatch repair or MMR deficiency. There's lots of acronyms. So MMR is mismatch repair, IHC stands for immunohistochemistry, and MSI stands for microsatellite instability. And this can all impact our treatment decisions, particularly regarding immunotherapy. So MMR protein complexes detect and correct mistakes that occur during DNA replication. The absence or loss of function of one of these four MMR proteins results in a mismatch repair deficiency, or you'll see DMMR or MMR deficiency. And so DMMR is what causes microsatellite instability, which is a condition of genetic hypermutability. And MSI high, so MSI, microsatellite instability high, provides phenotypic evidence of DMMR, again, MMR deficiency, and thus MSI high and MMR deficiencies are considered biologically the same population. And so that's really important just to get these terms in our head. What's relevant for GYN cancer, so, when I think about the VA population, a lot of people have a lot of experience with non-small cell lung cancer, which you use TPS or tumor proportion score for determining who might be a candidate for immunotherapy. And so in gynecologic cancers, we use the combined positive score, or CPS. And CPS is calculated by dividing the number of PD-L1 positive cells, so tumor cells, lymphocytes, or macrophages, by the total number of viable tumor cells, and then multiplying that by 100. So tumor cells require partial or complete membrane staining to be counted, while any staining counts for immune cells. And so, again, I'm just going to stress this important. This is just so important with talking with patients and in particularly veterans about the importance of molecular testing. Effective approaches providers can take to improve testing rates in the VA facilities includes counseling about the reasons for testing and the impacts of these results, understanding why a patient may decline or have concerns, clarify any misconceptions, and lastly, provide reassurance that findings will not impact claims on the presumption of a service-connected condition. It's really just, I can't stress this enough, that clinicians really need to reassure veterans that testing will not affect their benefits. Immunotherapy has shown significant promise for treating gynecologic cancers with approved treatments for endometrial and cervical cancer, and there's ongoing research for ovarian cancer and other rare types. My colleague, Angela Alvarez-Secord, will discuss in greater detail the use of immunotherapy for gynecologic cancers. But what you see here is that it's approved for frontline for locally advanced cervical cancer, along with chemoradiation, as well as in metastatic disease in combination with chemotherapy. In uterine cancer, IOs are approved in the frontline with chemotherapy, as well as second and third line regimens with tyrosine kinase inhibitors. The role of IO in the treatment of ovarian cancer remains investigational, which we'll discuss, but it is approved for metastatic or unresectable MSI high or tumor mutation burden high tumors, regardless of tumor type. So while you listen to Dr. Secord's presentation, I just want to give you two cases to sort of think about. So these are patients of mine that I've treated at the VA. We changed the names, but Monica is a 65-year-old veteran with high-risk locally advanced cervical cancer. She served in the Army. And so when we're talking about the cervical cancer trials, I want you to start thinking about what are important steps in evaluating this patient for treatment selection. And then we'll talk about Celia. She's a 78-year-old veteran with endometrial cancer. She served as a nurse in the Army between 1971 and 1973. And the things to think about are, how does biomarker testing play a role in treatment decisions? And do any comorbidities affect treatment selections. And we'll come back to these cases later. And now we will have Dr. Secord talk about checkpoint inhibitors in cervical cancer.
Wonderful. Thank you so much, Dr. Moss. That was really amazing. Just want to share, as a kid growing up in Montana, so wonderful to see you have a VA site on the map. Actually, my dad's internal medicine doctor, and he used to work there. So really thrilled to be able to have this opportunity to speak to all of you and help make sure that our veterans and their family members have access to care. So yes, checkpoint inhibitors are effective for cervical cancer. And let me just share some of the initial data with you. This was a single agent study called Keynote 158. Patients with PD-L1 positive cervical cancer were treated with single agent pembrolizumab, which is a checkpoint inhibitor. And you can see by these blue lines in the waterfall plot that there were responders. Most of the responders typically had PD-L1 positive disease, except there was one that was PD-L1 unknown. And the orange represents patients who are PD-L1 negative. The objective response rate was only 12.2%. However, there was deep responses seen in a few of those patients there, all the way to the right. And there was a duration of response that was felt to be of clinical benefit. And so this agent received FDA approval for treatment of patients with recurrent cervical cancer that was PD-L1 positive. Let's build on that now. And when we can talk about Keynote 826, this was a study that was conducted in patients with persistent, recurrent, or metastatic cervical cancer, and they had had no prior systemic chemotherapy. Prior chemotherapy was permitted with radiation, and they had an excellent performance status of 0-1. Patients were randomized to either pembrolizumab and paclitaxel with cisplatin or carboplatin every 3 weeks for 6 cycles for the chemotherapy part and up to 35 cycles for pembrolizumab. And bevacizumab was also included here, but it was optional. So this in the placebo arm was the control arm. The dual primary endpoints were overall survival and PFS, and there were the usual secondary endpoints. The findings I'm going to share with you shortly, but as a little teaser there, was FDA approved for the combination with pembrolizumab chemotherapy with or without Bev in patients who had PD-L1 positive disease with a CPS score of equal to or greater than 1. And here are the survival curves. Patients who received pembrolizumab, as shown by that dark blue or black curve, had a much longer progression-free survival in the all-comer patient population with a hazard ratio of 0.61. And then when you limit this to the patients who had PD-L1 positive disease based on the CPS score that I mentioned, the hazard ratio was 0.58. So a 42% reduction in disease progression. And when you evaluate the landmark analysis at 24 months, 35.9% of patients were alive disease-free or disease not progressing versus 18.8%. Remarkable benefit here. We're talking about in the 1990s when I was doing my residency that we didn't even think chemotherapy would help. And even though Dr. Moss showed that curve where the cure rates don't really seem to be improving that much in cervical cancer, we are making gains, and this study was a huge, huge game changer for us. Now, let's dive in a little bit more to the overall survival, which is even more exciting. In the all-comer population, the hazard ratio was 0.63, and then when limited to the biomarker-enriched group, it was 0.60, so 40% reduction in death. And this was truly meaningful and changed the standard of care for us. At the 24-month time period, 53.5% of patients were alive if they received pembrolizumab in the combination with chemotherapy with or without Bev versus 39.4%. I want to mention another study here that was very important. This is a BEAT-CC study evaluating atezolizumab, not pembrolizumab, but also a checkpoint inhibitor and chemotherapy. And this study, patients had bevacizumab. This was really critical for us because in the other study, it was at the discretion of the treating provider, which can create some issues with bias. And patients were very similar patient population, and they were randomized to receive the therapy here, and crossover from the standard arm to progression was not permitted. The dual primary endpoints here were investigator-assessed progression-free survival and overall survival, so PFS and OS similar to the study I just mentioned, and the key secondary endpoints were similar. This combination is not FDA approved, but it is listed in the NCCN guidelines as an option. What I want to show here is that PFS similarly was significantly improved in the atezo arm with a hazard ratio of 0.62, so almost a 40% reduction in disease progression. In terms of overall survival, hazard ratio was 0.68, so 32% reduction in death. You can see clearly that there's an advantage to IO therapy, and this was the second study to demonstrate this in this population. What's very unique about this study is that PD-L1 as a biomarker did not appear to be predictive for efficacy. So with the atezolizumab combination, you don't have to have that limitation of having a positive PD-L1 score. We can talk about the clinical implications of that later. I want to move now to locally advanced cervical cancer. The key eligibility here is a little tricky. So it's basically based on FIGO 2014 staging, and times change, staging parameters change. And so we have both of these staging guidelines to share with you. But this was specifically for patients who had stage 1B, 2 through 2B disease based on FIGO 2014 staging, or stage 3 or 4A disease that could be either node positive or node negative. So the earlier stages had to be node positive. Patients had to have RECIST 1.1 measurable or non-measurable disease, and they were treatment naive. So locally advanced cervical cancer is treated with chemotherapy and radiation. This has been a regimen standard of care for well over a decade. And in this study, patients received cisplatin at the standard dosing of 40 milligrams per meter squared weekly for 5 cycles, plus EBRT followed by brachytherapy with the pembrolizumab 200 milligrams every 3 weeks during that course of 5 cycles, followed by a higher dose of pembrolizumab, 400 milligrams every 6 weeks for 15 cycles. And this was compared to the control arm. Very important to note that all the patients here had radiation with brachytherapy, as well as external beam radiation. And this was conducted during a time of COVID. So it was really wonderful to see that a study of this magnitude could be done during a very challenging time. And here are the findings, and the progression-free survival at the initial interim analysis was positive at the 24-month rate. 67.8% of patients were without disease progression on the pembrolizumab arm compared to 57.3% of patients on placebo. The hazard ratio here was 0.7, so a 30% reduction in progression, which was, again, a huge win for us. And then in terms of the final analysis that was recently presented, the findings were overall stable, but now extended to 36 months. So with 3-year time point there, it was 64.3% of patients were without disease progression versus 55.6%, showing a consistent duration of benefit with pembrolizumab. In terms of OS, again, super exciting here. You see that the curves are very choppy, which is a manifestation of censoring. But at the 36-month time point, 82.6% of patients were alive compared to 74.8%. Bottom line, we need to do better, but at least this appears to be a gain. A little different analysis at the final time point where these curves start to come together a little bit, but again, censoring certainly appears to be an issue. This use of this combination with pembrolizumab in patients with locally advanced disease was FDA approved, but the caveat here is it is specifically FDA approved for patients who have 2014 FIGO stage 3 through 4A cervical cancer. Another important caveat is that you do not have to have PD-L1 positive disease to be eligible for immunotherapy in the locally advanced setting. We wanted to share the staging system for you. Believe it or not, it is really hard to find this with a lit search to compare 2014 and 2018 staging. 2014 staging is really primarily clinically staged disease, and 3A through 4A is shown here on the bottom. And it's very important that this is really based on a pelvic examination. You can use some information from radiologic imaging, for instance, if somebody has hydronephrosis or a non-functioning kidney, but it's truly more about the extended disease spread on exam. And this is compared to 2018 staging, which includes additional caveats such as radiologic imaging and pathology. So they're not quite the same, and it's really important to understand these distinctions, at least when determining whether or not a patient's eligible for immunotherapy with radiation, cisplatin in this setting. But I'm really excited about all these results. I mean, it's totally changed the way that we care for our patients. So Haley, I'm going to turn this over, or Dr. Moss, I'm going to turn this over to you again to discuss this case.
Yeah, so we're going to go back to the patient that we discussed a little earlier. So again, this is a patient who served in the Army. She was stationed in Germany. She has no history of military sexual trauma, and I just want to say that, studies have shown that 40 to 50% of women veterans have experienced military sexual trauma, so often patients are not getting appropriate cervical cancer screening due to avoiding like just routine GYN care. So this patient presented to her gynecologist with postmenopausal bleeding after never having received cervical cancer screening, despite being in her 60s or 70s. A PAP was obtained and a cervical biopsy, which revealed squamous cell carcinoma, poorly differentiated. At that point, what I will say that on exam, when you examine her, and again, going back to the different, staging, she had, bulky stage 3 disease on exam. She had a large cervical mass, and it felt like she had parametrial involvement. She had a PET scan, which revealed that she had an 8 centimeter cervical mass and diffuse pelvic lymphadenopathy. She saw my team at that point, and then we ordered PD-L1 testing, which showed she had a CPS or a score of 5. And so let's talk about this patient. So this patient is someone who, if you again go back to like the 2014 staging, Dr. Scorchi has like a bulky stage 3 disease. And so we're thinking about like, so this is a patient who has locally advanced cervical cancer. And so we're trying to think about like, what are her treatment options? So, tried and true, the most important part of her treatment or, is obviously the cisplatin and the radiation and making sure that she's seeing a radiation oncologist who can get her vaginal brachytherapy along with whole pelvis. But the question about like, is it relevant? Does the PD-L1 score matter in treatment selection for this patient?
I would say no, in this case, it doesn't. It's nice that you have it, though. It can maybe give you some comfort that she may be more likely to benefit, but I wouldn't utilize the PD-L1 score to say not to treat her.
Yeah, and when I was looking over your slides when you were talking about the trial where we're adding immunotherapy to frontline treatment for locally advanced disease, you didn't show it, but if I'm assuming that there are curves that exist for patients that are PD-L1 positive versus PD-L1 negative.
Across all of those studies, actually, there's these forest plots, and so you can see this differential benefit. And so one of the reasons, for why FDA might make one decision or the other is based on if they see a biomarker enrichment. In this specific setting, though, what I would like to say is don't wait for your PD-L1 score test results. If you get them, don't wait for them to start treatment on the patient. And then the other thing too, you talked about something like what's the most important aspect of this patient's care? While all of these things together, immunotherapy, cisplatin, and radiation matter, one of the most important elements is the radiation therapy and really making sure that your patient stays on time with that treatment and that they get the external beam treatment as well as the brachytherapy. I've just seen too many cases where sometimes brachytherapy is not done and the patient will get a boost. And that's not going to help your patient. No matter how much immunotherapy you give, they really need good radiation.
So normally these patients, so that kind of goes into the next question about how is the multidisciplinary team utilized. So treating locally advanced cervical cancer, so it's usually, Dr. Secord or I, so a gynecologic oncologist, and we're, ordering the cisplatin weekly and ordering the pembrolizumab, which will be, I usually do it every 3 weeks while they're getting their radiation, and then we start spacing it out to every 6 weeks. And then the radiation oncologist, and I can't stress this enough, is like having a radiation oncologist, who feels comfortable with IMRT for cervical cancer and making sure that a patient is going to brachytherapy and, really going to those appointments. And so this is, often very difficult for some of our, rural patients. And then also, and we'll talk about this a little bit more when we talk about toxicities related to immunotherapy, is having like a pharmacist who feels really comfortable with these drugs. So how would these conversations differ? So like, let's go through the same patient and say she was on that PET scan. It also showed that she had diffuse lung nodules that were consistent with disease. So how would you think about treatment and how would you think about biomarkers in that setting?
That's the keynote 826 population or beat CC. And this is where there's a very interesting difference in terms of the biomarkers, where you have one that's a biomarker-directed strategy with pembrolizumab that's FDA approved versus the other, which is evaluating atezolizumab, which is also a checkpoint inhibitor targeting PD-L1. So you have a situation where that study didn't appear that you needed the biomarker.
So usually in my situation, while I'm waiting for the PD-L1, I'm usually starting them on, the chemotherapy backbone and then, waiting for this to come back and adding pembrolizumab if they're eligible. And then just pulling up. So treatment plan moving forward. How long is she going to be on immunotherapy after she completes radiation?
But this is really important. So there's differences in these study designs, and it was 15 additional cycles, and you give it every 6 weeks. So it's 400 milligrams IV every 6 weeks. So it's not until disease progression, and a lot of these studies have different duration of treatment time. So it's really important to familiarize yourself with the study and make sure you have the duration of therapy correct.
Yeah, exactly. So unfortunately, my patient, did recur, but after a year, which, these patients with really bulky cervical cancer, a year on immunotherapy after finishing radiation. So now we're just going to talk about safety considerations for immunotherapy regimens. Immune checkpoint inhibitor toxicity is also known as immune-related adverse events, can affect any organ system in the body. So I'm not going to go through all of them, but these autoimmune-like toxicities are known as complications for therapies, and they can include skin or dermatologic, gastrointestinal, endocrine, pulmonary, neurologic, among others. And the onset and severity of these adverse events can vary significantly. And so we encourage you to identify experts in each relevant subspecialty to assist with the management. So I have a running list of all the subspecialists at my institution who can help with any toxicity ranging from endocrinology and dermatology to pulmonology. And I feel like, and Dr. Screw, you could agree with me, I think with the advent of, e-consults, it's been really helpful. So, strange increase in creatinine because patients can have, rare renal toxicities. I routinely send, e-consults to my nephrology colleagues, which is very helpful. Immune-related adverse events can occur at any time during immunotherapy with immune checkpoint inhibitors, but they most commonly appear within the first few months of treatment. Rash, hepatitis, and hypothyroidism were the most common toxicities. RAS has the fastest median time to onset. Sometimes often patients will just say, just with that first cycle, they just kind of feeling itchy after their treatment, and maybe they see some type of very mild rash on their arms or their lower extremities. It's important for patients and providers to be aware that a patient can have a really dynamic trajectory with new onset toxicities weeks to months after starting. And actually, before we did this presentation, we were just talking about, so that patient who got, radiation, which we know causes diarrhea, but then also getting immunotherapy, sometimes it's really hard to tease out what's actually causing the toxicity. And sometimes you need to hold the immunotherapy to see whether or not the diarrhea improves or not. And it might just be, radiation related. In general terms, so it's outside the scope of this presentation to discuss the management of each toxicity. And I really encourage everyone to regularly check the NCCN's clinical practice guidelines in the management of immunotherapy-related toxicities. It's incredibly helpful. But briefly, grade 1 toxicities in general can be managed with close monitoring, with the exception of neurologic, hematologic, and cardiac toxicities. Holding drug is necessary for mild to moderate grade 1 symptoms, and corticosteroids may be administered during, depending on the toxicity. Now we're going to go to grade 3 and grade 4. So grade 3 toxicities require holding the drug and initiating high-dose corticosteroids and potentially infliximab, depending on how a patient is responding. So we get this question a lot about re-challenging with immune checkpoint inhibitors after grade 3 toxicity. It's complex. It requires careful considerations. Some patients can be safely re-challenged, but you should really counsel the patient that's at a really high risk of recurrence when a patient's had severe toxicities. In the setting of grade 4 toxicities, which warrant hospitalization, permanent discontinuation of checkpoint inhibitors is needed, with the exception of certain endocrinopathies, which can be managed, but that would be something that you would manage with an endocrinologist. This slide highlights organ-specific management of different toxicities. I really just stress using the clinical practice guidelines in the management of immunotherapy-related toxicities from NCCN, because you can go through defining every grade and what the recommendations are for treatment and managing. And now we're going to talk about checkpoint inhibitors in endometrial cancer.
Yay. Well, this is another area where checkpoint inhibitors have changed the standard of care for our patients and are routinely assessed for use in patients with endometrial cancer. I want to start first by reviewing the FDA-approved first-line immunotherapy options for patients with endometrial cancer. You can see the FDA approval timelines were all similar in 2024. So let's talk about RUBY first. RUBY evaluated patients with advanced or recurrent endometrial cancer not treated with prior chemotherapy. Previous adjuvant chemotherapy was allowed if it was completed greater than or equal to 6 months. Previously, they had excellent performance status. A really important caveat for this study is that it allowed patients who had carcinosarcoma to enroll on the study to a certain cap. Patients were stratified based on their microsatellite status, whether they had MSI high versus MS stable tumors, their disease status, stage 3 or 4 versus recurrent, and whether they had prior radiotherapy or not. They're randomized to either dostarlimab with carboplatin and paclitaxel for every 3 weeks up to 6 cycles, and then dostarlimab was extended for up to 3 years, and that extended dosing period time, they received 1,000 milligrams every 6 weeks, which is a lot easier to deliver therapy every 6 weeks than having them come back every 3 weeks. And this was compared to a placebo control arm. The primary endpoints here are important to note is a dual primary endpoint with progression-free survival and overall survival, with secondary endpoints being objective response rate, duration of response, safety, and patient related outcomes or quality of life parameters. And then shown here are the survival curves. The progression-free survival benefit I'm going to show you first was in the deficient MMR, MSI high population. Outstanding hazard ratio. I don't think we'd previously seen this before in patients with endometrial cancer. Hazard ratio was 0.28, so 72% reduction in disease progression. Patients who received dostarlimab is shown by that blue line there. At 2 years, 61% of patients were progression-free compared to 15.7% of patients who received placebo. The next slide shows the overall survival benefit. Again, absolutely outstanding. In fact, the median overall survival had not been achieved in patients who received dostarlimab. Compared to those patients on the placebo group, the median OS was 31.4 months. So exciting results that definitely change the standard of care for these patients. Now, the FDA approval was for dostarlimab with chemotherapy followed by single agent dostarlimab for patients with either dMMR or PMR disease at this time. And we can discuss more about the PMR patients, but we didn't show the survival curves there for RUBY. I'm going to show them here for the GY018 study. So very similar patient population. There are a few small caveats in terms of a 12-month parameter of adjuvant chemotherapy rather than 6 months. Performance status was extended to include patients with a PS of 2. Patients were stratified on dMMR status, ECOG performance status, and prior chemotherapy, so a little different on the stratification factors. And they were randomized 1-to-1 with pembrolizumab and carboplatin versus placebo. And you can see that the pembrolizumab was extended up to 14 cycles in this study. And then I want to share also the primary endpoint is different. It's PFS in patients with dMMR disease and PFS for patients with pMMR disease. So not the PFS and OS, but rather PFS in these very different biomarker stratified groups. Secondary and exploratory endpoints is not a comprehensive list, but some of them are overall survival in those 2 different biomarker groups, PD-L1 status positive or negative in the pMMR and dMMR groups, investigator-assessed PFS by PD-L1 status in those 2 groups, and then the BICR versus investigator-assessed outcomes by MMR status. And the results are, again, equally striking. On the deficient MMR cohort, the progression-free survival was dramatically improved with a hazard ratio of 0.3, so a 70% reduction in disease progression, and favoring the pembrolizumab arm. And, I mean, these curves are so separate from each other. It's just truly outstanding. And then in the PMR cohort, we also saw this benefit. And I think this is really important to note because this is the only trial out of all of those that was specifically designed to evaluate the benefit of IO therapy in patients with pMMR disease. So this isn't an issue of conflicting trials. This is an issue of this was the only one that was designed to really, truly study the effect of IO in patients with pMMR cancers. So the hazard ratio here is still fairly strong. It's not quite as robust, but still 0.54, so 66% reduction in disease progression. And we're talking about a median PFS of 13.1 versus 8.7 months. But again, you can see the area under the curve for the pembro chemotherapy arm is very dramatic. resulting in FDA approval for pembrolizumab and chemotherapy, followed by a single agent maintenance pembro in patients with either dMMR or pMMR disease. And then next, we're going to talk about DOE. And I also want to say there's other trials out there as well that we didn't explore, but are also evaluating other IO agents. We concentrate on these three and following the FDA approvals. And this was conducted in patients with newly diagnosed disease or recurrent disease. They had to be naive to frontline systemic anti-cancer therapy. Prior therapy was allowed. This time it was greater than or equal to 12 months, similar to the GY018 study. Patients had to have known MMR status, prior radiation was allowed, and all histologies were included except for sarcoma. So high-risk histology like carcinosarcoma was also included here, similar to Ruby. Stratification this time included geographic region, and you'll see that there's 3 arms, not just 2. And one of the interesting arms here, and the IO arms are very similar. It was a durva instead of pembro dostarlimab, but what was very interesting here was the incorporation of olaparib. And so in arm A and B, it was either placebo or durva, and then you had a placebo for olaparib, and then arm C was platinum chemotherapy and the durva, followed by maintenance with olaparib and durva. And it was very interesting to evaluate this in terms of the primary endpoint. It was PFS for arm B versus arm A, and then PFS for arm C versus arm A, which I think is important to note these different comparator arms. Secondary endpoints include OS, PFS2, objective response rate, and duration of response. And the results here for the dMMR group show that those lines, it is really important to note, for durva plus olaparib, that darker line versus durva alone, which is that light blue line, they pretty much overlap. So in the dMMR group, it does not appear that olaparib confers additional benefit over IO therapy with the chemotherapy background. But compare both of those arms to control, and you can see that the IO regimens clearly result in enhanced disease control with reduced progression. The hazard ratio for durva plus olaparib is 0.41. For the durva arm, it's 0.42. And then turning attention to the next slide over is OS in that group. Again, very similar OS advantage. It's just absolutely striking the huge difference that we're seeing in terms of patients who are alive. At the 18-month time point, it was almost 90% of patients compared to if they're on the control arm, 66%. In fact, median OS was not reached for either of the IO-containing arms. And in 2024, FDA approved durva and chemo followed by single agent durva, specifically in patients who had deficient MMR disease. All right, so let's go next to this slide. And I think clearly IO chemo combinations are now the standard of care for patients in the first line setting who have endometrial cancer, most definitely for those with deficient MMR. The GY018 study supports the inclusion of IO with chemotherapy in patients who have pMMR disease as well. And so this was the groundbreaking results that changed the standard of care, which is really exciting. However, there's still some patients who will have progressive disease despite chemotherapy, despite in combination with immunotherapy. And it's important to identify what are the other options. So prior to these studies being released, there was Keynote 775. So this was predominantly at a time when we were not using IO in the frontline setting. And it was a very exciting study because at that point in time, our options for patients with recurrent disease is very limited. And patients with endometrial cancer don't go on to get all these different types of chemotherapy regimens. They usually just have few opportunities to try to get disease control. What was really astounding here is this study was, I would call it a triple win. Median PFS was improved, median OS was improved, and response rate. And this was with a combination of lenvatinib and pembrolizumab. So targeting the immune component with pembrolizumab, and then lenvatinib is a tyrosine kinase inhibitor that targets vascular endothelial growth factor, fibroblast growth factor, and platelet-derived growth factor, as well as other pathways. And you can see that while the progression-free survival is deplorable for both of these arms, the hazard ratio of progression for death was reduced by was 0.6, so 40% reduction in disease progression. And the overall survival side, 30% reduction in death. And the objective response rate was so much higher. It was really double, 32.4% versus 15.1%. And this combination received accelerated approval initially, followed by full approval in 2021 for patients who had endometrial cancer that was not MSI high or deficient MMR. So really offering an option for patients with proficient MMR disease. I'm going to turn it back to you, Dr. Moss, for the patient case.
When you were giving that slide, because we're not really going to talk about the toxicities of lenvatinib and pembrolizumab, but that was a really fun combination to try to tease out what was causing the diarrhea. And we're using lenvatinib a lot less now that we have so many patients getting immunotherapy in the front line and doing well and not needing that second line treatment. Okay, so now we're going to talk about this patient. So Celia was a nurse in the Army from 1971 to 1973. She is now a 78-year-old. I actually just saw her in clinic, but she looks like she's like 52. Excellent performance status. She presented to her gynecologist with postmenopausal bleeding in March of 2025. She had an endometrial biopsy that revealed a serous type endometrial carcinoma. She underwent a robotic-assisted laparoscopic hysterectomy, bilateral salpingo-oophorectomy with a pelvic and para-aortic lymph node dissection. She had stage 3C2 measurable disease, meaning on imaging, we were able to see enlarged lymph nodes. The vast majority of them were resected at the time of surgery, but she still had disease left at the conclusion of her surgery. We did biomarker testing, which showed that she was MMR proficient. HER2 testing showed an IHC of +1, and she has a P53 mutation. So this is a patient, I hemmed and hawed a lot about what would be her treatment. So the first thing we're going to discuss is when should testing occur for a patient with advanced stage disease at diagnosis, Dr. Secord?
So I readily utilize the tumor biomarker, specifically mismatch repair testing, to determine if germline testing is needed, as well as family history. In this case, she has a pMMR cancer. I don't see any notification of family history, so I wouldn't necessarily do germline testing. But if she had deficient MMR without promoter methylation of MLH1, then I would do germline testing for Lynch syndrome. The other thing here, when I think about papillary or serous endometrial cancers, I think about BRCA1 mutations. So that's why she had a family history or other personal cancer history of breast cancer, that would also lead me to go to germline. Somatic testing, I'm very interested in somatic testing in these patients to help me determine what would be their next therapy if they have progression or recurrence. But I'll be honest, I'm not completely convinced about the timing for when somatic testing should be done. I know that can be somewhat controversial.
Well, just to go back to, because we were talking about how PD-L1 testing for our cervical cancer patients sometimes takes a really long time. This is usually easier because usually these are not, send out tests, and our pathologists locally are able to, tell us these biomarker testings. So the reason why you are probably like, well, do I need to do biomarker testing? How would it change things? So this is a patient who has bulky stage 3C disease, uterine cancer. And so how do you think about the fact that she's MMR proficient in terms of, are you going to give her immunotherapy with her carboplatin and paclitaxel?
So there's so many different options here, right? I think one of the key things is her HER2 status is just 1+. We can talk about that for a long time too. So if someone has a HER2 3+ or 2+ with FISH positive in the frontline setting, I'm going to add a trastuzumab with chemotherapy approach there. But most importantly, I'm going to offer patients clinical trials if I have them open. In the lieu that she does not have overexpression of HER2, and let's say I don't have a clinical trial available, I would offer her immunotherapy with chemotherapy in this patient population. And there's a lot of controversy about P53 mutations being predictive or not. And there's one study that said yes, there's a study that says no, but I think it's very reasonable given GY018 was the only study that was really designed to evaluate this question in the pMMR group.
So what I'm saying, so you would give immunotherapy for MMR proficient. So what if it was the same patient and instead of doing a full lymph node dissection, I just did sentinel lymph node testing, and I had one sentinel lymph node that was positive. Otherwise, you get a CT scan. She has no evidence of disease on her imaging, and she's MMR proficient. So is that a patient that you would give immunotherapy to with her chemotherapy?
No, I would not. And that's based on the B21 study. That was a negative study. The caveat here is measurable disease versus non-measurable disease. And the idea of somebody has measurable disease, you're treating with chemotherapy, neoantigen release that may help trigger the immune system, and that may be the mechanism of action by which these two different types of regimen synergistically or additively improve response and outcome.
So the next question is, what if testing results showed MMR deficient? I think that's, very clear from the presentation that, she would be a candidate for immunotherapy. The one thing that, we should also discuss is side effects. So this patient presented to me cycle 2, and she started just having, just a mild rash on her arms. And so it's important when you have a rash is like first to do like a total body skin assessment to see if they have a rash anywhere else in terms of looking at their skin and like the total body surface area. In general, how I manage a mild rash, which, a lot of patients get these rashes, I usually just tell them, a trial of an oral antihistamine. And, sometimes if it's really bothersome, they can use like a moderate potency topical steroid. If the rash is worse than a grade 1 rash, those are situations where I would hold immunotherapy, but I usually work very closely with our dermatologist who specializes in immunotherapy and with our pharmacist. The other, toxicity that this patient didn't have, but a lot of our patients have is diarrhea. And Dr. Score, do you want to just talk a little bit about, a patient who's presenting and she's having, 2 episodes of diarrhea a day? How do you usually counsel them?
Well, sometimes it can be hard to determine where the diarrhea is coming from, so I think in those situations, 2 episodes a day, brat diet, Imodium, and then just really making it important for the patient to know they need to call. If they start experiencing 4 to 6 episodes of diarrhea a day, we need to know about it. If they're having abdominal pain or blood or mucus in their stool, that's important. We recently had a patient who didn't have any diarrhea, but she had severe abdominal pain. And that, if you have severe abdominal pain, it could be due to colitis, and that would be grade 3. And so those patients should be strongly considered for steroids. And I'll tell you, I have a very low threshold for getting the GI service involved. And if patients don't have a rapid response to steroids, then consider alternative. Well, number one, you need to make sure there's not an infectious etiology too. I should back up. And then supportive care. But, I have a low threshold for getting them involved because you want to make sure you're treating the right thing.
Yeah, I think the theme of this is that there's a lot of multidisciplinary care with the management of IO-related toxicities, and there are some institutions that that have immunotherapy consult services. So if a patient is admitted to the hospital with an IO-related toxicity, then instead of calling like a general GI consult or derm or endocrine, then you call the IO team, which I think is really fascinating to see those that exist. And now we're going to talk about checkpoint inhibitors in ovarian cancer.
Yeah, unfortunately, this is going to be a lot quicker discussion. We have not found the magic yet in ovarian cancer. These are several of the studies that have been completed. ATHENA-COMBO, DUO-O, KEYLINK 001, and FIRST. You'll see the status in terms of the findings. No improvement for ATHENA-COMBO seen in PFS or OS utilizing the strategy. The improved PFS that was seen in the other studies noted here, I honestly think the driver of that is the PARP inhibitor. I don't think it's the immune therapy. So that is my personal assessment of the data. I do not strongly recommend IO therapy for patients with ovarian cancer unless it's within the context of a clinical trial. This was a study that we did at Duke with 2 other centers. It was actually a study that Dr. Moffitt did. Dr. Wyndham did at Moffitt, and we were really excited to be part of it. It was evaluating weekly paclitaxel with pembrolizumab in patients with platinum-resistant ovarian cancer, and the response rate was really high. There was 51% partial response rate in the evaluable cohort, and in the treated cohort, it was 46.3. So there's 2 different cohorts based on whether patients were eligible. Sometimes, you have patients that get on a trial that may not quite fit the eligibility criteria. But nice to see that waterfall plot there. There were no complete responders. So this study helped inform the B96 trial, actually. It's B96, evaluating pembrolizumab and paclitaxel plus or minus Bev in patients with platinum-resistant disease. And the schema is shown here. So patients receive pembrolizumab every 6 weeks for up to 18 cycles with paclitaxel plus minus Bev at treating physician discretion, and the control arm is placebo. There was a press release in May that said it met its primary endpoint, and we're really excited to see what these findings show, and hopefully that'll be presented later this year. But as of right now, I do not typically use IO regimens in unselected patient populations with ovarian cancer. If they are eligible for an IO based on that tumor agnostic approval, then consider it. And the tumor agnostic approval is based on deficient MMR and TMB and some other caveats there as well. So I'm going to turn this back over to you, Dr. Moss.
Thank you. Okay, so this is the last slide. So as I mentioned earlier, we still do not have like a really good grasp of the stage distribution and histology of veterans with gynecologic cancers. But with the help of NAVREF and partnerships with academic centers, we are working to develop databases to better understand this population. We have the benefit of being in the largest healthcare system in the country with a single EMR that includes over 9 million patients. And so with the help of our academic partners and NAVREF, we can work on asking like really important questions that really matter to our veterans, such as how does deployment impact women and their potential for cancer risk? And do environmental exposures lead to more aggressive molecular subtypes of cancer? And these are just a couple of questions that my team is working on. And the other thing that through the National Tele-Oncology, now that I'm meeting veterans, around the country with these GYN cancers, I'm working really hard to enroll them in clinical trials. We know that greater participation in clinical trials leads to better outcomes and patient access to new therapies. So it has been like such a pleasure of mine to meet veterans in the state of Texas or Washington or you name it, and then I find the local academic partnership with that VA to enroll them in clinical trials, and that's thanks to a lot of the work with NTO and with NAVREF. I think we have a few questions. What's your best advice for helping a patient manage GI issues while on therapy? So for patients with, with grade 1 toxicities, so after you've ruled out any like other infectious etiology, you could still continue them on immunotherapy. And so for those patients, it's like symptomatic relief. So loperamide is sometimes patients' best friends. And also sometimes it's dietary and reducing high fiber foods that might make someone a little bit more prone to diarrhea. Do you have anything to add? So patients with a mild colitis.
Yeah, I talk to patients a lot about the brat diet, bananas, rice, apples, toast. Not that exciting, but the most important thing is call us if that diarrhea worsens. If you're having more than, if you're having 4 to 6 episodes or 7, if you're having more than 7 episodes, we need to know about it. Abdominal pain, blood or mucus in the stool, and really make sure that your nursing team is aware.
What guidance do you have for streamlining workflow for clinics and clinic staff using immunotherapy regimens? Nurse triage, take-home info?
Oh, we're so lucky. Dr. Moss and I are very lucky. We have these incredible pharmacists who works with us both at the Duke site and our Macon Pond site, and they have just been so wonderful taking care of patients and being able to provide them all these discussions in terms of the side effects, what to watch for. Take-home information, I think, is helpful, but patients forget. We do have a nurse triage line, but just always having that contact us if you have any questions. And, I actually think that immunotherapy can have so many different types of side effects. I actually think patients should be wearing something saying, I'm on immunotherapy. So if they go to the ER with some strange side effects, that the ER docs know they're on this immunotherapy. And immunotherapy side effects can happen even after the patient's been off treatment. I have seen that as well.
How do you explain the difference between checkpoint inhibitor treatments and other treatments for gynecologic cancer in a way that patients can understand?
Well, so Dr. Moss, when you were describing how you describe it in terms of hiding from the immune cells for immunotherapy, I think that's exactly the way I describe it. So I was wondering, like, maybe we got that messaging similar, but I use the Harry Potter invisible cloak idea, where the cancer cells are just, able to hide behind that cloak. The immune cells are out there trying to find them, but they can't. And then that immune therapy essentially takes off that cloak so that cancer cell can't hide anymore. And the immunotherapy can do, or the immune cell, their own immune cell can do the work and destroy those cancer cells. And that's different than chemotherapy drugs that have a variety of mechanisms of action.
And then the last question is, how do immunotherapy seem to affect your patient's quality of life versus chemotherapy? I find that for patients who are on immunocheck, if it's not causing side effects and they're doing well, sometimes they're asking me if I'm even giving them a drug. That being said, patients that do have toxicity can feel, really unwell. And that's different than chemotherapy, where I feel like across the board, patients have like some level of fatigue and some low level of toxicity, even if they're tolerating it.
Yeah.
Do you agree with that?
I would. I think the rates of really severe grade 3 or higher toxicity with immunotherapy is probably in the 10 to 15% range, whereas in some patients tolerate really, really well, but you need to be aware of the side effects because when they happen, they can be pretty significant. I just want to add too, there's some really exciting studies coming on in the endometrial space of evaluating immunotherapy compared to chemotherapy in patients with deficient mismatch repair cancers. And if those are positive, we may enter a new era where you could drop the chemotherapy backbone. But some people may argue you don't have the right control. So we can come back in the future and discuss this again. It's really exciting how fast the trajectory of care is changing, and being able to offer our patients meaningful treatments that improve disease control and overall survival is a huge win.
Thank you for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the National Association of Veterans Research and Education Foundations. This activity is supported by independent educational grants from AstraZeneca and Merck & Company Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/DVK860.